Welcome to this program on optimizing the prevention of herpes zoster in older adults. What we hope to accomplish is to increase awareness of the impact of herpes zoster and its related complications on older adult patients, provide clarification regarding the latest guidance for herpes zoster vaccination, boost clinicians' confidence in recommending herpes zoster vaccination, and help to improve vaccination rates and thereby help to improve herpes zoster primary prevention. I am Dr. Stefan Gravenstein and Director for the Center for Geriatrics and Palliative Care at University Hospitals Cleveland Medical Center and Professor of Medicine at Case Western Reserve University Medical School in Cleveland, Ohio. With me is Dr. Thomas Feil, Chair of Infectious Disease Division at Summa Health System in Akron, Ohio, and he is Professor of Internal Medicine, Master Teacher and Chair, Infectious Disease Section, Northeast Ohio Medical University in Rootstown, Ohio.
This program is comprised of a series of 4 parts, 4 different videos. The first video, which is this, focuses on herpes zoster epidemiology and risk factors and is intended to provide background and content for the other 3. The second, which covers acute and chronic manifestations of herpes zoster, as well as complications of the disease, includes discussion of the sometimes very serious impact of herpes zoster on individuals' daily functioning and quality of life, and highlights vaccination as the best strategy for prevention. In the third video, we'll cover barriers to vaccination for herpes zoster, and this sets up a discussion in the fourth video of effective strategies for overcoming barriers and persuading patients to receive the vaccine.
Now let's turn to the part 1 of the series, Etiology and Epidemiology of Herpes Zoster and Risk Factors for Contracting the Disease. Here we have Frederick. Fred is a 63-year-old previously healthy man, and he comes with a 3-day history of some pain in his chest and now has a red vesicular rash following T2 dermatome on his right side. He describes the rash as painful and itchy. Tom, could you explain what causes this eruption?
Well, as you know, Stefan, each of us had chickenpox as a child, and so we know that herpes zoster is a reactivation of that same virus. But as we look at this graphic here, when we had chickenpox, usually the vesicles, which are generalized on our body, they usually start on the trunk and the face, and they can spread throughout the whole body. And that rash lasts for about 2 to 4 weeks. But that's not the end of it, as we know, because the virus can actually, or at least part of the virus, can actually travel down the sensory nerves to the ganglion root area of the nerve, of the spinal nerve, and establish a latency. So it can remain dormant there for years and actually decades, but then it can reactivate. And when it reactivates, it causes inflammation of that ganglion, which is associated with significant pain usually. And then the virus can travel back up the sensory nerve and cause the rash, the vesicles, at that site on the skin. Now, we know that the dermatomes that will be involved in that rash would be associated with the specific spinal nerves where reactivation occurs. And I'm showing you the mapping of the dermatomes of the spinal nerves on the left-hand part of this slide, and then the cranial nerves on the right-hand part of the slide. Now, if we look where that patient's rash was, to me it looks like it was either T3 or T4 type of dermatome. And usually in an immunocompetent host, it usually is only one dermatome, but we know that in immunocompromised patients, it could be actually multiple dermatomes. And then if we refer to the cranial nerves here, I just want to point out the ophthalmic division of the trigeminal nerve, because if it involves the tip of the nose, which is the ciliary branch actually, we have to be concerned about significant infection in the eye, and we'll be discussing that in one of the other videos.
Zoster is much more common than most people realize. In the general population, it's about 4 cases per 1,000 adults per year. And for those over the age of 60, it's 2.5 times that, 10 cases per 1,000 per year. There's a lifetime chance of getting zoster of about 1 in 3. And for those people who make it to age 85, they have roughly a 50-50 chance of getting zoster. 1 million new cases each year, and recurrent zoster occurs in about 6%. That's, the risk for this is double in those who are immune compromised at 12%. When we're talking about immunocompromised individuals, we're referring to those that have malignant disease, such as metastatic cancer or cancer that's requiring active treatment, radiation therapy, or immunosuppressive therapy. We're talking about people with organ transplants, including bone marrow transplants. We're talking about people on chronic steroids, such as for asthma or COPD. So there are quite a few people who are immunocompromised, and the degree of immunocompromise directly relates to the degree of their risk for developing zoster.
Yeah, well, we're seeing a lot more of this is the patients who are receiving biologics, anti-TNF agents for rheumatologic diseases, dermatologic diseases, GI.
The DMARDs and so forth.
Exactly, and so this is increasing the risk for a large portion of the population.
Great.
So we know that patients develop increased predisposition to developing herpes zoster as their cell-mediated immunity declines. And this occurs as we age. I mean, it starts perhaps at 50, 60, but really when we get up over the age of approximately 80, where it really starts to decline significantly. We also know, as you mentioned, Stefan, that patients who are on suppressive therapy, whether it's bone marrow or other organ transplants, diabetes, HIV with lower CD4 counts, patients who have lymphoma or Hodgkin's disease, leukemia, or autoimmune diseases, as we mentioned, these patients are at higher risk for reactivation and developing zoster.
And at what CD4 count do you think that the risk really begins?
At 200. So if they're certainly below 200, they're certainly a higher risk. And it's a variable gradation. I like to see actually patients above 500 to be much more clear as far as their immune status. And we also know that there is a gender and race predisposition. I mean, white race and females tend to have a higher rate of zoster as well. And then those who suffered physical trauma, there's a higher rate of zoster occurrence. Now we know, and you mentioned, that 99.5% of adults over the age of 40, and certainly our age, have serologic evidence of prior varicella infection, chickenpox. But we know that the younger age group who have been receiving the vaccine, that this is almost gone. I've seen many of our residents who have never seen a case of chickenpox, which is kind of interesting. It shows the dramatic benefit of the varicella vaccine, which has been available since 1995. But herpes zoster is also preventable. There is a vaccine available since 2006. Interestingly, the incidence is increasing, perhaps because of the reasons we mentioned, those increasing percentage of the populations that are at risk, but it's unrelated to vaccine efficacy.
So you don't think that because we've been giving a chickenpox vaccine that they are now potentially at greater risk in the future for getting shingles because it's not as effective as the disease itself?
I don't think so, but we certainly do know that patients who received the varicella vaccine still are at risk to getting zoster.
Mm-hmm. So here you can see the incidence of herpes zoster by age. And the lines go progressively from the top to the bottom, from oldest to youngest. So you can see over the last 50 years, zoster incidence has been increasing in all age groups, most dramatically in the oldest age group. And this is likely unrelated to the availability of the varicella zoster vaccine, which you heard was back in 1996, the introduction of the antiviral therapy back in the 1980s, or change in the prevalence of immunocompromised adults. The increasing risk for zoster, with age at least, and in general is thought to be considered related to the decline in cell-mediated immunity. We have different ways to measure cell-mediated immunity, and one would be, for example, with skin test results. On the left side here, you can see a graph that shows as you get older, your skin test reactivity goes down. And that directly relates to the risk for developing zoster. On the right-hand side, another measure of cell-mediated immunity is interferon gamma. And you can see again, with age, the interferon gamma that you can measure elicited from cells also goes down.
Well, now let's turn to some of the complications of herpes zoster, and I think the most significant one, the one that causes the greatest disability for our patients, is postherpetic neuralgia. And this is defined by pain that persists after resolution of the rash. Now, definitions vary. It could be after 30 days, 60 days, 90 days, 120 days. I like to think about it as after 30 days because I think even that is a significant association with pain. And this may last months to years, and it occurs increasingly with age, or the older the patient, the more likely they are to have postherpetic neuralgia. And pain is likely to be severe, and it usually requires some form of pain management, which can be very difficult in many patients.
Does the, how long after, this classification of 30, 60, 90, or 120 that you use to define postherpetic neuralgia, does that change how you approach the treatment?
Not really. I mean, if they're having significant pain after 30 days, I'm really wanting to, for the benefit of the patient, try to relieve that pain, try to relieve that discomfort, because it affects their daily lives.
So the name doesn't change the treatment?
I agree.
Yeah.
And this looks at the relative rate of postherpetic neuralgia associated with age, and this is from a study from the United Kingdom, but it shows that as patients age, particularly when they get above the 80s, that the incidence of postherpetic neuralgia is very significant. And this is another study from the United States. It's actually from a metropolitan area in Minnesota, again looking at the relative rate associated with age. And if you look at the left-hand part of the slide, you can see that it really starts to go up quite steeply after the age of 50. And then on the bar graph, you can see that patients over the age of 65 have a 17% incidence of postherpetic neuralgia, whereas it's much less under the age of 65. So we also know that the risk for postherpetic neuralgia will also be associated with other factors during the initial herpes zoster episode, such that the greater severity of the rash, the greater pain associated with rash, I like to call this zoster-associated pain, or ZAP, actually. And then the older age group have increased risk factors for postherpetic neuralgia. And as we've already said, those that are on immunosuppressive or immunocompromised agents would be at higher risk as well.
So in this graph, you can see severity of zoster and the duration of chronic pain in adults over the age of 50. And what this is supposed to show in the top versus middle versus bottom lines, folks that have the most severe rashes or discomfort at the onset compared to those that have the least severe, the bottom line. So the most severe is lots of lesions, more than 47, or at least moderate pain, and 21 lesions in the top bar, or severe pain and under 47 lesions. And you can see the more lesions you have, or the more pain you have at the beginning, the worse your prognosis in terms of duration of chronic pain that follows. In the bottom one, they have, this is a group that has no or mild pain and fewer than 20 lesions. And you can see they resolve pretty quickly within a few weeks. So there's lots of other complications you get from zoster, and you heard Dr. Feil refer to some of these. And one of the most serious ones that we worry about is the zoster ophthalmicus. You can also get bacterial superinfection of herpes zoster lesions. That's typically with Staph aureus and sometimes group A beta hemolyticus, streptococcus. You can get cranial and peripheral nerve palsies aside from the ophthalmic nerve, disseminated zoster, visceral involvement, such as of the pleura or the brain, and stroke and heart attack have also been associated with zoster complications.
And so if you look at the rate of patients who have received vaccination, it's not very high. I mean, obviously the vaccine's been available for about 10 years, but if you look at least the last bar on this graph, 2014, only 27% of patients who would be eligible to receive this vaccine have received this vaccine. And if you look at the benefit of the vaccine, it's actually to boost the cellular immunity. I mean, if you look at this graphic here, once you have infection with the varicella virus, there is a robust response by the immune system, the cellular immune system, as you can see in this slide. And then periodically, if we are exposed to chickenpox, for example, when our children develop chickenpox, of course that's not happening so much as it did in the past with us, with our children, because of the vaccine. But if we are exposed to chickenpox, that sort of boosts our immune system. You can actually have subclinical cases of reactivation that may boost the immune system as well. But we know from what we've said that as we age, and if there's other underlying conditions, our cell-mediated immunity wanes. And if it goes below a certain threshold, such as shown on this slide, then we are at risk for developing herpes zoster. So the goal of the vaccine, as shown in this slide as well, is to boost that cellular immunity after a period of time when we would be at risk, to reduce that risk of developing zoster.
To summarize then, herpes zoster is increasingly common, and aging is the most important risk factor due to a decline in cell-mediated immunity. Postherpetic neuralgia is the most common complication of herpes zoster, and risk factors include aging, severity of pain and rash, and immunocompromised status. Herpes zoster is preventable. Vaccine stimulates cell-mediated immunity, and vaccine rates remain surprisingly low. Only a third of the population that is eligible for this has been vaccinated, and it gives us a huge opportunity to do better. I want to thank you for your participation in this video, and Dr. Feil for joining us. I hope you will join us for the next video in the series, Clinical Impact of Herpes Zoster and Its Complication. In addition, I would like to point out helpful resources for clinicians and patients pertaining to herpes zoster vaccine recommendations, as well as recommendations for other adult vaccines. One is the Adult Vaccine Schedules from the Advisory Committee on Immunization Practices, ACIP, on the CDC's and American Academy of Family Physicians website. And the other one is from the Gerontological Society of America, the National Adult Vaccination Program, which you can find on the GSA's website. Thank you for joining us.